I'm Kristine Erlandson. I'm an associate professor in the Division of Infectious Diseases, and my clinical work and research has primarily focused on people with HIV, looking at some mechanisms of aging and implementing interventions to ensure successful aging in people with HIV. This research has focused on frailty and exercise interventions, which actually had a nice parallel with some of the long COVID and follow-up COVID symptoms. And so I currently have a study looking at exercise interventions in people who were hospitalized with COVID and was asked to give this talk today on what is PASC. So thank you to the organizers of today's conference for the opportunity to talk with you today about PASC. And I think everyone can see my slides and hear me okay, but please speak up if you can't. Make sure I got that. There we go. Okay. So I just wanted to start and make sure we're all on the same page regarding some of the terminology. As I'm sure many of you have seen, there's been a lot of different terminology that refers to the long-term symptoms that people experience with COVID. The NIH has used this term PASC, or post-acute sequelae of SARS-CoV-2 infection. Probably more commonly on the media or in the news, we see the term long-haul COVID or long haulers. Other terminology has included many different phrases such as post-acute COVID, long-term effects of COVID, and post-acute COVID syndrome, which are essentially all referring to the same types of symptoms. I also wanted to mention that while there is some and growing published data on the epidemiology and symptoms of PASC that I will present, I've also included a lot of news clips and commentaries and editorials and consensus statements, as there's also not a lot published on some of the long-term impacts and mechanisms and treatment that we associate with PASC. I'm sure most of you have at least seen some headlines on the impact of PASC and predictions of the long-term impact that PASC is expected to have on our healthcare system. If you didn't see it, there was a really nice editorial or perspective piece in the New England Journal by Dr. Phillips and Williams confronting our next national health disaster, long COVID. And indeed, I think many people do fear that this may be a huge long-term effect, even well beyond that which we've experienced with acute COVID. And in particular, some of the individual patient experiences and stories are really striking. Dr. Sarah Jolly runs our COVID clinic here, and she had an interview that was on the CU Anschutz 360 podcast. I have the link in the bottom here. If you have a chance to review it, it's a really nice story and gives a great perspective on what patients are really experiencing with PASC. The young woman that she interviews, similar to many of the patients that are seen in the post-COVID clinic, was a collegiate athlete up at CU Boulder, and she was in an excellent shape prior to acquiring COVID in March of 2020. She describes her experiences in this podcast, including her delayed diagnosis of COVID, a lot of the unknowns that she faced in trying to find treatment and care for COVID, and her frustration with how this long COVID or PASC syndrome really changed her ability to do the things that she loved, such as singing, mountain biking, and many other activities. Even minimal exercise would give her a severe headache and leave her completely exhausted for days. And now she's over a year after her initial treatment. She's beginning to get some of her strength and endurance back, but still continues to have very marked symptoms from her initial infection. And I think she's a really excellent example of what a lot of patients are experiencing after their initial COVID infection. So what really is PASC? Well, there's actually quite a bit of debate via this very specific definition of PASC, but the general consensus is that PASC encompasses a range of symptoms that are persistent for or develop 4 or more weeks after the initial infection with SARS-CoV-2. PASC can be kind of difficult to distinguish from other complications of COVID. Cardiac complications that we'll hear about in our next speaker can contribute to tachycardia and chest pain, which can be some symptoms associated with PASC. Symptoms related to hospital complications or post-ICU weakness, post-ICU conditions such as weakness and DVTs can contribute to some of the symptoms we see in PASC. There's certainly psychologic effects from the social isolation and long-term effects of PASC long-term effects of COVID that can contribute to some of the fatigue of PASC. And then with many patients, they had new diagnoses of diabetes, hypertension that they didn't previously have and were diagnosed during their initial hospital stays with PASC. And both these conditions and the treatment could contribute to some of the symptoms that we see in post-COVID. I think it's also important to mention what PASC is not. So importantly, PASC is not a condition that has known diagnostic tests or biomarkers, at least yet. It's also not the same as the multisystem inflammatory syndrome that we see particularly in children. And although some complications of COVID, like myocarditis and pneumonia, may worsen symptoms of PASC, these may have very different treatments and certainly should be evaluated and treated separately and not just kind of attributed to PASC. And really all post-COVID syndrome or symptoms that develop should be further evaluated to ensure there isn't a misdiagnosis or a treatable cause of those symptoms. In fact, some providers have reported some important misdiagnoses such as new strokes or lung cancer diagnoses that providers had attributed to symptoms just related to post-COVID that actually had a clear treatable cause. Reports of the prevalence of PASC differ quite widely depending on the study population or the publication, but it seems to occur in probably between 15 to 30% of patients that had COVID. Although this ranges anywhere from about 10% to more than 80% in some different study populations. The long-term impact of that with our current numbers of COVID cases is that PASC will probably impact more than 15 million people in the US alone, possibly much more depending on what happens this fall with the Delta variant. There's an ever-expanding list of publications on the epidemiology, symptoms, and kind of the characteristics and long-term effects of PASC. And I've included a few of these here. In particular, there's a couple of very nice reviews. The first review listed here in Nature Medicine from April, as well as the final publication on this list that was a review from in the BMJ from June of this year. Although we don't have a great understanding of who does develop PASC, it's surprisingly common among those that were actually healthy and fit prior to their COVID diagnosis, those that were not hospitalized with COVID, and even some diagnoses among those that never had symptoms of COVID, but later tested positive for antibodies or in surveillance testing. For example, in some reports, they have found that up to 1/3 of patients with PASC actually had asymptomatic COVID. Although men tend to develop more severe COVID, women seem to be at greater risk for developing PASC. And similarly, although older individuals likely have higher mortality from COVID, PASC and the development of PASC symptoms seems to be more common in a middle-aged population. This does mean that this could have a pretty important long-term impact with a great effect on that population that's really in their prime working years and prime family raising years. One thing that's been really remarkable about PASC is this robust patient advocacy. This patient advocacy has probably led to some of the early reporting of symptoms, ongoing support and recognition of PASC, rapid gathering of ideas for both the causes, the treatment, management, and even influencing the National Institutes of Health to call for more funding to support PASC initiatives. For example, Twitter has numerous different support groups, some of which are comprised even of healthcare workers that have experienced long PASC and help to develop treatment guidelines. The Patient-Led Research Collaborative is one of the largest groups that has really pushed forward the research agenda. This group is comprised of researchers who actually developed long COVID early on in the COVID epidemic back in March. And some of the founders of this group have backgrounds in machine learning, cognitive design, and public policy, and have been very influential in informing the PASC research agenda. This group actually presented some of the first findings on PASC using a survey that they distributed on social media venues back more than a year ago in April and May of 2020. They surveyed patients that primarily had symptoms. About 90% of patients that participants that answered their survey had symptoms. They captured responses for 640 different participants at that time, most of whom were not hospitalized and were reflective of that population at greatest risk for PASC, mostly female, Caucasian, and middle-aged. Importantly, and we see this in some other studies, they found that only about 25% or about a quarter of their population actually had a positive test for COVID. About almost 30% tested negative, although they do note that the median time to testing was quite a bit later, more than 2 weeks after the initial onset of symptoms, so it may have been some misdiagnoses. And about 50% of patients or participants in both this study and another study I'll talk about were never tested for COVID. Do you remember this was back in March and April of 2020, at which time we were really limiting COVID testing to patients that were coming in for hospitalization. And so this is again reflective of that population that primarily remained outpatient and never required hospitalization. The group asked about some typical COVID symptoms that we were seeing quite frequently in patients that were following up, such as fever, cough, and ongoing dyspnea. But they also asked about some new symptoms that were not necessarily being asked about at the time in our clinic follow-ups back in March and April of 2020. Notably, they found that many patients were experiencing symptoms like fatigue, brain fog, difficulty concentrating and trouble sleeping, and a loss of appetite. And this was one of the first reports to really show these neurologic symptoms that were much more common than had been previously recognized. A subsequent study by this group was published via preprint or was posted on PubMed on preprint in December and published in the Lancet last month. And again, this was the patient-led research group. They surveyed for this study over almost 4,000 survey participants from all over the world. And we see that same test distinguishing or differences in testing. So only about 1,000 actually had a positive test, and the majority either weren't tested or had a negative test. For this survey, they assessed a very wide variety of symptoms, including over 200 different symptoms. The survey was estimated to take at least an hour to complete, and actually much longer in some of the patients that were experiencing severe fatigue. Similar to the other study, they found that a very high proportion of patients or participants had symptoms, likely reflective of the biases they had in who wanted to participate and complete the questionnaire. And again, a fairly low percentage of patients that were hospitalized. So in this large survey of almost 4,000, they found that the average number of symptoms that patients had were 14 symptoms at 6 months. So this is a group that's really experiencing a pretty significant symptom burden, most commonly that being a fatigue, post-exertional malaise, which I'll talk about more in a minute, and cognitive dysfunction. And this is it was a really rich publication, lots of different tables and figures, which are pretty interesting to go through, and I encourage you to read it if you have a chance. But I wanted to point out a couple of interesting differences they found in this study. So in the purple square up in the upper left corner, you'll notice a difference between that orange line, which is those that tested positive for COVID, and the blue line, which are those that tested negative for COVID. And this difference in smell and taste was actually the only significant difference that they found between those that had positive testing and negative testing, suggesting that this negative testing group probably, or the group that didn't get tested or had a negative test, may be reflecting a very similar population in that all of their other symptoms were quite identical. The second thing I wanted to point out is that you'll notice some of the symptoms that I've outlined in the red boxes, like insomnia, memory issues, speech language, and this post-exertional malaise, have a later onset. They have a peak that occurs about 2 months after the initial diagnosis, in comparison to a lot of the respiratory symptoms and other symptoms that seem to start more at the time of diagnosis or during the hospitalization. I just wanted to mention one other kind of large study that I think is quite informative. This was a study that was done in the Veterans Health, or using Veterans Health Administration data. They included over 70,000 VHA users who survived for at least 30 days and were never hospitalized with COVID. And they compared that to 5 million VHA users who did not have COVID and were not hospitalized during that same time period. Using propensity scores, they calculated what they called the excess burden of various conditions and symptoms between comparing those who had COVID and who did not have COVID. I've listed these in descending risk, or in the descending frequency of symptoms. So the most common symptoms that were, or the greatest excess burden of symptoms was that of respiratory conditions, which were seen much more commonly in those that had COVID. We also see some interesting other conditions, such as an increased risk of hypertension and metabolic conditions, such as disturbances in lipid balance, or in lipid markers, obesity, and diabetes. We see those same neurocognitive conditions, such as sleep-wake disorders, nervous system conditions, some musculoskeletal pain, and then that same malaise and fatigue that come up again and again. So as I've shown in a few of these studies, some findings certainly seem to be unique to COVID, and long haul syndrome, or PASC, and are much different than what we see in other post-viral conditions such as the flu. One of the most common findings that we're seeing in the PASC population is this profound fatigue. And this may be both physical fatigue and cognitive fatigue, or even emotional fatigue. And patients really report this profound fatigue after even minimal exertion. This could be mental exertion. Someone goes back to work, they find themselves kind of in the grind all day for 8 hours, and they are mentally and physically exhausted after that exertion and thinking really hard for that period of time. This is probably worsened by some of the sleep-wake disturbances that we're seeing common in PASC. And this does tend to overlap some with what we see reported in chronic fatigue syndrome, that post-exertional malaise or post-exertional fatigue. Another finding that we're seeing in PASC is that of dysautonomia. Patients have tachycardia or postural or orthostatic hypotension that is unexplained by some of the cardiac findings that we're seeing in follow-up. A lot of patients are reporting these neurologic conditions such as brain fog, sleep disturbances, tremors, and other kind of strange neurologic symptoms that don't seem to necessarily be pinpointed to a certain condition. Notably, many of these symptoms have a relapsing and remitting nature. Patients may have good days when they feel they're maybe starting to get back to normal. They perhaps exert themselves a bit more on those days because they feel good. And then that day is followed by a profound crash when they really feel horrible for a couple of days, and it takes several days to make up and get back to their baseline. We don't have a clear cause of PASC at this point, but potential hypotheses include that there's a persistence of the live virus. This may explain why some people have an improvement, perhaps even up to 50% of people have an improvement in PASC symptoms following vaccination. There's some studies that suggest there's ongoing inflammation or immune activation in response to the virus. Some of the symptoms are suggestive of an autoimmune type sequelae. Others have suggested that there may be some reactivation of latent viruses such as cytomegalovirus or Epstein-Barr virus. And then others have suggested there may be a component of what's called mast cell activation syndrome. This initial lack in symptoms or lack of understanding and kind of newer appreciation of symptoms that didn't necessarily fit into specific disease silos to facilitate referrals to different subspecialists were probably some of the main factors driving the initial development of what are now known as post-COVID or long-haul clinics. Pretty amazingly, numerous health systems across the world scrambled to assemble these multidisciplinary clinics in the matter within months to create several different clinic structures of post-COVID clinics. Recent estimates are that we have at least 44 different health systems that have put together post-COVID clinics. And the Survivor Corps group, one of the patient advocacy groups, actually has a nice summary and directory of what clinics are available in each state. Here in Colorado, we've been fortunate enough to have the post-COVID clinic at the university, the clinic was founded by Dr. Jolly, and patients are seen in conjunction oftentimes with Dr. Thant from psychiatry. This clinic has received hundreds of referrals. I think close to 500 patients have been seen over the course of the last year, and they have a very long waiting list, really emphasizing the need for this type of care and the ongoing burden of post-COVID symptoms that patients are experiencing. Several other clinics are established in the state, including a clinic at National Jewish, in Boulder, over in Fruta on the Western Slope. And these clinics have brought together lots of different expertise in pulmonary and cardiology care, pulmonary, physical, and occupational therapy, as well as behavioral health and neuropsychiatry. The general management really involves first a detailed history and physical to understand what symptoms a patient is experiencing. And then further testing is driven by the types of symptoms that patients are reporting. A lot of further workup the further workup is going to be through a workup of dyspnea through 6-minute walk test or pulmonary function testing or chest imaging. Certainly a lot of referrals and further workup for some of these neurocognitive symptoms. And then some clinics have introduced some really unique aspects. I found one clinic that's offering smell training for patients that have lost their sense of smell from COVID. We really do not have any established guidelines or treatments, very little data on how we should be treating patients with COVID, but a group of clinicians in physical medicine and rehabilitation, including some clinicians from the university, recently published a consensus guideline that's in press and provides some recommendations for management. One of the main points they emphasize is the importance of ruling out other causes and contributing factors, as I mentioned earlier, making sure patients have that echo or CAT scan or whatever other tests they need to make sure we're not missing another explainable and treatable cause. Most of the guidelines are focused on helping patients overcome some of the fatigue and post-exertional malaise that are so common with post-COVID, helping patients to titrate their activity, continuing to increase activity in very small amounts as patients tolerate to ensure that they're not having a worsening of symptoms. Exercises consist of submaximal cardio exercises, so very low pace, just a slow, easy exercise, some light strengthening exercises and stretching to gradually work someone's pace back up to normal. Some of the other recommendations stem from recommendations in the chronic fatigue literature, such as small, frequent meals that help with ongoing energy throughout the day, ensuring adequate water and electrolyte intake for those that might have symptoms of orthostatic hypotension. The guidelines importantly also emphasize some of the disparities and inequities in care that we're going to see with PASC. Many patients probably won't be able to access some of these care and rehabilitation programs. They may not have the ability to have some flexible work accommodations to help overcome some of the fatigue and experiences they might have when they try to go back to work. And then food insecurity and housing can certainly interfere with some basic components of rehabilitation in this population, including good nutrition and a good night's sleep. So lastly, in spite of the long road that we have ahead, as was recently published in a commentary in the British Medical Journal, I think long COVID really does provide an opportunity for the medical profession to move beyond stale controversies and reconsider how we can discuss symptoms lacking clear causes with patients, students, and colleagues. PASC really has provided a remarkable infrastructure for multidisciplinary evaluation of patients, both here in Colorado and throughout the world, and can hopefully pave the way for some new discoveries in both in long COVID as well as chronic fatigue and other symptoms that may mimic these types of conditions. And in particular, we hope that we can be a site for some of the future studies, including the NIH PASC Consortium, to further evaluate and contribute to the advancement of our knowledge and help with developing new treatments for these patients. I just wanted to quickly thank Sarah Jolly for her input on slides and help providing a case, some of my collaborators and mentors for their ongoing experience, Dr. Sokol and the CCTSI leadership for the opportunity to present today, and then really the patient advocacy community for helping to move this field forward. And with that, I am happy to answer any questions.
Hi, Heather Pidcoke from Colorado State University. Given some of the access to care issues that we've heard about today with communities of color, I'm wondering what sort of specific advocacy the university has planned for people with long COVID who have less access to care?
Yeah, I think that's a great question. So as far as in my understanding, especially in talking with Dr. Jolly, and she's on the call too and can add if I'm missing something, but the post-COVID care has been provided essentially as part of the COVID package that the state has covered for patients with COVID care. And so she's actually had a very diverse patient population that's followed up. So I think in general, most of the post-COVID care has actually been covered well. I don't know how much outreach has been necessarily done, and there certainly could be patients that aren't aware of the post-COVID clinic. We are hoping to be a part of this long PASC or this PASC consortium through the NIH, in which case we have started to strategize about lots of different ways that we can ensure outreach, and are working with several of the community groups to ensure that we can get a wide variety of patients of different backgrounds involved in the long COVID follow-up. Sorry, I missed a couple of questions in the chat. So the first question was, what is the most consistent objective finding with PASC, laboratory imaging, et cetera? I think that's part of the tricky part with PASC, because a lot of it isn't necessarily objective. There's a huge emphasis on symptoms. There are some memory T cell studies. I don't know if Brent Palmer's on or not. He's been conducting some of that work here at the university. And could provide a little bit more detail on that. I don't know all of the details as he hasn't published anything yet that I'm aware of, but I think there's certainly in some of the discussions about developing the PASC consortium was a lot of discussion about whether or not we should be including some of these negative COVID testing patients. I think the general consensus in the larger studies and kind of understanding the pathogenesis moving forward is that there is a limited number of patients that have tested positive or never had a positive test, so that we really can confirm that these symptoms are associated with positive testing. But I think that's an area of controversy. And it's certainly, we don't want to necessarily exclude that initial cohort of patients who just didn't have access to testing because it wasn't available. And Carrie asked, do we know if there's PASC in folks who are vaccinated and have a breakthrough COVID infection? Great question, Carrie. I don't know that. Sarah, have you seen any breakthrough or long COVID? I don't know if we've even had vaccination long enough to see that. Do you know if there's been PASC in vaccinated patients who have a breakthrough? And I don't know if Sarah's on.
Yeah, I'm here, Kristine. We've definitely seen it with second COVID infections. I don't know if those were people that were vaccinated or just had a second infection. We've seen some people who have symptoms worsen with vaccination, and then you've probably heard report of some people who have improvement in symptoms. So I think understanding the role of vaccination will be important going forward.
Any other questions or comments? We have about 1 or 2 more minutes. Otherwise, we can continue on. I did have a slide on children. I think we don't know a lot about how often PASC is occurring in children so far, but it does appear that up to about 10% in some studies are children experiencing PASC. I think as we start to see these huge outbreaks as school comes back in and we have a large unvaccinated population in the schools, we'll learn a lot more, unfortunately, about how often PASC is occurring in children.
Kristine, this is Ron Sokol. I just wonder if you have a minute, if you want to briefly outline what the OTA plans are all about, what NHLBI is planning for studying PASC.
Yeah, so there was as many of you know, there was a call for PASC consortiums or kind of establishing a large PASC study from the NIH in the spring. And our site, in conjunction with the site in Utah and New Mexico, submitted an application. We passed the first step and we were asked to help develop a protocol and submit a budget that went in July, and we're waiting to have updates on that. We think there's a good chance that we will be selected as one of the sites. Our site would be the Mountain States Consortium, so we would be collaborating to enroll patients both here and through Denver Health, and then a couple of sites in Utah, in Salt Lake City, and then in New Mexico. And we went in with a focus on some unique issues with COVID, including a Hispanic population, a Native American population, and then kind of the high altitude question that I think our sites are uniquely positioned to help answer. The overall cohort would enroll 10,000 adults, trying to capture people who don't have COVID, who were hospitalized for other reasons during this time period, a group of people who are acutely developing COVID who acutely develop COVID, and then we follow them over time to see if they have ongoing symptoms and who does or doesn't develop COVID. And then a group of people who had COVID who don't develop symptoms or who do not have long haul or past symptoms, and a group of people who do. So kind of a several different groups that we can include. Their patients will be followed, or participants will be followed quarterly, undergo blood draws, a lot of other different collections. And then there's kind of a tiered approach to, based on what kind of symptoms people report, they might be directed down a neurocognitive pathway and have more intensive neurocognitive workup. If they have cardiac symptoms, they might undergo echo and further cardiac workup. So we're hoping that we can be a site for this, and if so, we'll enroll several hundred patients, both between here and Denver Health. So if anyone has patients that you're seeing in clinic that are reporting or that have past symptoms and are interested in following up, or had COVID or just interested in more research, I'm happy to chat with them more about the study going forward. So.